Done, sir. We are live.
Yeah, thank you.
Thank you.
A very good evening and welcome you all for this wonderful session under the program Rheuma DG Conclave. Uh, you all are welcome to this live webinar. Today's topic is Patterns of Arthritis by Dr. VIGNESH.M. Dr. VIGNESH.M. He's a MD DM consultant rheumatologist and practicing at Apex Center for Rheumatology, Warangal, Telangana. Moreover, going into the brief introduction, I would like to take you through the brief introduction of Dr. Vignesh.M. He is a consultant rheumatologist, MD, DM. Most importantly, he is the first DM rheumatologist in Warangal running a state-of-art, easily accessible and approachable center for treating patients with rheumatic disease. He is well known for his communicative skills and patient care that makes a lot of difference in the patient's life. Secondly, he's a well-read teacher and a motivational expert as well. And moreover, as far as research work is concerned, many topics that he has delivered the sessions as well as the poster presentation at national as well as the international platforms under the topic like utility of positron emission tomography in patients with systemic sclerosis and ILD, lupus pneumonitis, a review from a tertiary care center, and outcome assessment of a patient with SPA on ifiximab and etanercept in a tertiary care center. Then unmet needs in a contraception among reproductively active female patients with SLE, which is systemic lupus erythematosus. Utility NLR in an assessment of a disease activity of a patient with rheumatoid arthritis. And the last topic, which is hepatocellular carcinoma presenting as a systemic vasculitis. So thank you very much, sir, first of all, for taking your precious time for us. I welcome you on behalf of the entire audience today we have, and from the Zydus Synovia family. Welcome, sir. Welcome for this session, and thank you very much for contributing your time and sharing your knowledge today with us on this platform. Over to you, sir.
Well, thank you for the kind introduction. Can I start? Yeah.
You can share your presentation.
A very fine, good evening to one and all. So thanks for the kind introduction from Mr. Vishal. For your kind words, thank you so much. So today we'll go into the topic of patterns of arthritis. So rather than going into the terms of patterns of arthritis, learning rheumatology and understanding rheumatology is like solving a puzzle. Okay, so patients come with the cluster of symptoms, and you start to work like Sherlock Holmes to find out what pattern is the patient following with the joint symptoms and what sort of disease is the patient getting out. Okay, so majority of the times it would not be on a single day you can diagnose a case, but you have to follow up for a close follow-up for the pattern in which the joint symptoms present with, which would make a dramatic difference. Rheumatology is all about pure clinical science. So when you take a proper clinical history with a complete physical examination, majority of the time you would not miss the diagnosis. And yes, we have wonderful laboratory investigations to be done to confirm the cause of arthritis and to confirm the pattern of arthritis, whether it is fitting into the same disease or not. We have a lot of advanced investigations, but however, still you should remember that clinical diagnosis is the hallmark of rheumatology. So this is our center. So it has been about 1 year since we have opened the Center for Rheumatology. So it's going good. Patients are happy. I'm also happy along working with this management on this Apex Center for Rheumatology, right? So there are 6 doubts that commonly needs to be addressed, not only for rheumatic patients. Take it for example, any disease, be it diabetes or hypertension or rheumatoid arthritis. You talk Greek and Latins, whatever you talk might be looking like Greek and Latin to your patients, but a few questions comes up to the patient's mind whenever you diagnose a chronic disease. Okay, the first thing is, what is wrong with me? Okay, what is wrong with me? And second thing is, what will happen if I don't get treated? Okay, if I don't get treated, I'll face the complications, right? So what can you do about it? And what can I do about it? So what are you going to do and what am I supposed to follow? So on follow-up, the patient might ask, am I getting better? And if I'm not improving, am I receiving the right treatment? Am I receiving the best treatment? Or is my diagnosis wrong? So these sorts of questions and queries comes to every patient who attends a rheumatology clinic, be it with a diagnosis of osteoarthritis or be it a diagnosis of systemic vasculitis. Yes, these are the 6 common questions we need to address. So in order to address these questions, we must be able to uh, accurately pick up the diagnosis, fix up the diagnosis, without which prognosticating such patients really becomes a very difficult job, right? So, rheumatology is a subspecialty of medicine that deals with disorders of bone, joint, and connective tissue disease. So, these connective tissue diseases predominantly affect the joints, but it is not only joints, rheumatic diseases are all the rheumatic diseases are multi-system disorders. Okay, so I see recent news in 2018 in Indian Express. Despite a very high burden of rheumatic diseases, still there is no national program for rheumatic diseases. Probably people are not aware about the rheumatic diseases. Okay, yeah, even they are aware, they are ignorant about the diseases, be it osteoarthritis or systemic sclerosis or a systemic vasculitis or a malignancy causing arthritis. So people are not aware about it, people are not guided properly. And yes, despite a high burden, there is no national program for managing rheumatic diseases. So, how do we improve? The problem right now is we have a very less doctor to patient ratio. In that meaning that the rheumatologists are very less concentrated around the metro cities, not into the three-tier cities, and that is one of the reason I had to shift to Varangal. Being a three-tier city, becoming in the next smaller city, there are a lot of patients who are in demand for a rheumatologist, but they do not know that they have to reach a rheumatologist and get treated appropriately. So the doctor to patient ratio is very low for treating rheumatic diseases. But with increasing awareness and with increasing number of rheumatology seats, both DM and DNB, that this problem would tide over time. Okay, so when there are a lot of doctors, treating becomes easy. Okay, diseases could be diagnosed at early stages. See, I don't see quite often patients with rheumatoid arthritis and deformities. Majority of my patients are being referred to me thanks to the treating physicians who are around me, who are able to refer me the cases at the earliest time possible, that is less than 3 months, which would make a dramatic difference in managing these patients. So early treatment is mandatory, and right now, treat to target is the recent and wonderful concept. Like you target the HbA1c for diabetic patients, you target the BP for hypertensive patients, you target some outcome measures in treating rheumatic diseases. So there are a lot of scope for improvement, and imagine rheumatology is a wonderful subject to understand, assimilate, and practice. The Okay, so people might think it is only a disease of joint. What to do with that? Okay, we deal with joint pains, but not only the joint pains. So we deal with a lot of diseases like inflammatory arthritis, its spectrum. Okay, post-viral arthritis, rheumatoid arthritis, psoriatic arthritis, axial spondyloarthritis, ankylosing spondylitis, enteropathic arthritis, reactive arthritis, and crystal arthritis. So we deal with such a lot of inflammatory arthritis and its spectrum. We deal with systemic autoimmune connective tissue diseases like lupus, scleroderma, Sjogren, inflammatory muscle disease, MCTD, vasculitis, and mimics. So, on seeing this big list is still not ending. We also deal with soft tissue rheumatism, degenerative conditions, lot of osteoarthritis patients. So these patients need a lot of education and counseling, fibromyalgia, osteomalacia, osteoporosis, and especially our rheumatic patients, steroid-induced osteoporosis. Okay, so we do not treat only joints, we treat the patient as a whole. So that is the fun, that is the dedication what we rheumatologists show to our patients. Okay, so how do we recognize the patterns of arthritis? For this, you need to take a proper, complete history. Okay, so the first time when a patient comes to us with a joint pain, try to probe as much as possible to find out the onset of the disease. When you ask some patients, they might say that, sir, I'm having pains for 2 days, 3 days. When you probe and probe and probe and probe, sometimes the history may go way beyond 15 years also. So please probe as much as possible to find out the onset of the disease. And okay, if at all it's going to be the pain, what is the source of the pain? So this is the next thing which you should understand. A patient with joint pains can either develop a pain because of a primary problem in that particular joint, for example, knee joint, or it could be a referred pain from the hip joint. Okay, so it can arise within the joint because of inflammation of the synovial membrane, which is synovitis, or degeneration of the joint, which is mechanical degenerative osteoarthritis, inflammation at the level of enthesis. So enthesis is nothing but your Achilles tendon getting inserted into the calcaneum. So the point of insertion of Achilles tendon into the calcaneum is called as an enthesis. And inflammation at this enthesis is going to be called as enthesitis. So enthesitis could be a source of a pain. Patient might say, I'm having an ankle pain, but it is not the ankle joint pain, it is the enthesial pain. Okay, some patients can present with swelling of an entire digit, inflammation, pain of the entire digit, which is called as dactylitis. Some patients can have periarticular pathologies like bursitis and capsulitis. Last but not the least, a very high chunk of patients do suffer from a very difficult to treat disease, which is called as fibromyalgia, wherein patients can have tender points and trigger points, which will be making our job difficult to localize the source of pain. Okay, the patients would have allodynia, patients would have an abnormal sensitivity to touch, they feel a lot of pain even while we touch, and these are the sources of joint pain. So first of all, we must be able to clearly delineate from where the pains are coming up. Okay, so a few causes of pains and how do we differentiate is what we should know from this chart. So when you take a bone pain, okay, so a bone pain can be because of a tumor, okay, or because of a fracture, okay. So bone pains, or if at all, a child who is coming with severe bone pains and fever, it could simply be a leukemia. So patients would feel pain even at rest, also at night times. So when you palpate the bones, there will be tenderness, and especially while treating a child with fever and arthritis, if the child is going to have a sternal tenderness, you should always rule out a leukemia. So bone pain. So whenever a patient complains of a knee pains, you should see whether the pain is coming from the bone or is it coming from the joint. So when you take a mechanical joint pain or an inflammatory joint pain, so this we'll be discussing shortly in the next slide. So mechanical joint pain is when you overwork the joint, the patient would have pain. Okay, inflammatory is because of inflammation. So always in any patient with a pain, you need to differentiate whether the pain is a mechanical joint pain or an inflammatory joint pain. So we'll come to that shortly. And apart from this, the periarticular symptoms. So how do we differentiate an articular pathology from a periarticular pathology? Okay, so articular pathology, what I mean is a gouty arthritis or an osteoarthritis affecting a single joint. Periarticular pathology, what I mean is either bursitis, tendinitis, tenosynovitis, or enthesitis. So these are periarticular structures which are getting affected and the patient is having pain. So in a periarticular pathology, the patient would be having pain only on selected movements. Okay, and there would be localized tenderness. For example, a patient with Achilles tendinitis would have insertional tenderness of the insertion of Achilles. Okay, and if a patient is having a tenosynovitis of the wrist, patient can have a localized asymmetric swelling of over your extensor tenosynovium. So the patient would be having a typical swelling along the course of the tenosynovium, which might be very prominent in such patients. Bursitis, so in the typical location of bursa, you can have swelling, pain, and yes, this is not going to affect your articular movements completely. Majority of the periarticular pains, patients would be having difficulty in active movements rather than passive movements. Whereas when a patient is having a intra-articular pathology, the patients would be having pain in both active and passive movements. So there are a lot of ways you can differentiate an articular pathology from an extra-articular pathology. And this is the first and foremost step to differentiate in a patient with a joint pain. And next thing what you're saying is neuropathic joints. So neuropathic joints usually have changes of a mechanical damage, which is osteoarthritis, but they would have coexistent neuropathic changes. Okay, they would have atrophy of the muscles, they would have sensory disturbances, they would have ulcers, they would have painless ulcers, trophic ulcers, which would be helping us in making up the diagnosis. Referred pain, I've already discussed about it. So there are potential causes of pain which we have to assimilate before making up a diagnosis for the cause of the pain. A very, very important point which we have to discuss, that how do we differentiate an inflammatory pain from a mechanical pain? Okay, so pattern recognition in arthritis has a lot of steps. Okay, so this class would be this webinar would be like a clinical discussion rather than discussing on studies and evidences, because if I want you to talk about pattern recognition, I have to go at the most clinically to make you understand things better. So, inflammatory versus mechanical pains. This is the next topic. A characteristic example of an inflammatory joint pain is rheumatoid arthritis, and a characteristic example of a mechanical joint pain is osteoarthritis. So, when you say patient with rheumatoid arthritis, the patients would come with a pain, okay, and this pain would be associated with a swelling, okay, and the patients would have symptoms more in the morning, okay, and they would have a significant early morning stiffness of more than 30 minutes. Okay, once the patient starts moving the joint, the patient's joints would improve, the pain would improve. People would say that I woke up in the morning, I'm not able to fold my fingers, and as I start working, as I start cleaning the utensils or start cooking, by around 8 or 9 o'clock, I get better. So, this is how the typical history of inflammatory joint pain is given by females suffering from rheumatoid arthritis. Okay, sometimes the pain may be at rest. Nocturnal pain is notorious, especially for spondyloarthritis or an infective pathology, causing inflammation. And when you take rest for 5 minutes, you will again develop stiffness. So, this is a characteristic history which you would get from a patient with a rheumatoid arthritis. Whereas when you see in a patient with osteoarthritis, so osteoarthritis is a mechanical joint pain. So, what you have is the pain worsens with movement, and it is worse in the evening because from morning till evening you move a lot, so the patient's pain would be more and more. So, when he takes rest, the patient will be feeling comfortable. Okay, and here also the patients would complain of stiffness, but stiffness is short lasting here. Be it a morning stiffness and or be it stiffness after rest for less than 2 minutes, and this phenomenon is called as gelling. So gelling, that is feeling of stiffness for a very, very short period of time, is characteristic of a mechanical joint disease or osteoarthritis. So while you examine a patient with say for example, in inflammatory joint disease, an inflammatory knee joint, so you would have a firm rubbery swelling. Sometimes you might have a spindle-shaped swelling, especially in your fingers. When the PIP joint gets involved, you get a spindle-shaped swelling along the PIP joint, and you would have a joint line tenderness. Okay, when the synovium is inflamed, you press the inflamed synovium, so the nociceptors are triggered, so the patient would have joint line tenderness. Usually there is no crepitus unless and otherwise the patient develops a secondary osteoarthritis. Patients would have all the signs of inflammation, not all the signs every time. So patients would have warmth, redness, erythema, effusion, and tenderness. Okay, so extraarticular signs are common. What I mean to say is if a patient is coming with wrist pain, patients might have extraarticular symptoms like rheumatoid nodules or Zika symptoms. If it is lupus, the patient is going to have malar rash, photosensitivity, and so forth. And it can affect any joint. So based on the disease, the joint prediction would differ from patient to patient. While you discuss a patient with osteoarthritis, which is a mechanical joint pain, the swelling what you see in osteoarthritis is not because of synovial proliferation. Yes, some patients with osteoarthritis can have a coexistent synovitis, but majority of the time is because of a bony enlargement. Okay, and you can have nodular swelling in the fingers, which are called as Heberden's nodes and Bouchet's nodes, which are characteristic of osteoarthritis. Okay, and you can still have a joint line tenderness here. So joint line tenderness would not be a finding to differentiate mechanical pain and an inflammatory pain. So when you have a tenderness, it could either be because of a mechanical cause or it could be because of an inflammatory cause. Usually there are no inflammatory signs, no systemic signs, but remember in osteoarthritis also, some of the time you would develop some warmth, effusion, and synovitis with synovial thickening. Yes, osteoarthritis, previously it was thought to be a purely mechanical process, but still there are some cytokines which are involved in the pathogenesis of osteoarthritis. And you see osteoarthritis in the predominantly weight-bearing joints like hip, knee, and also in the hands. So hands, though not a weight-bearing joint, hand OA is gaining its importance on the recent days. Okay, so when you have a patient with joint pains, okay, you assess the pain, you assess the stiffness, you assess if there is any swelling, and if the patient is having a long-standing pain, you ask for deformities, you look for deformities. And when a patient has a chronic arthritis, what happens? The intrinsic muscle, the muscles which are around the joint goes for wasting and atrophy. And because of a malalignment of the joint can go for instability, and at last there would be a loss of function. Apart from this, you should look for general symptoms like constitutional symptoms, sleep disturbances, and systemic diseases that are pointing out to the reason of the joint pain. And yes, there are some red flag signs like any focal neurological deficit or any significant fever or weight loss. Okay, so there are a lot of symptoms which you should analyze for every patient with a mechanical or an inflammatory joint pain. Okay, so when we go systematically, so when a patient coming with polyarthritis presents to you with a headache, if it is going to be a young female, you have to think of lupus. Okay, and if it is going to be an elderly female, you have to think of giant cell arthritis, which is because of the inflammation of your temporal arteries. Okay, it's a large vessel vasculitis. When a patient with inflammatory polyarthritis presents with numbness or paresthesia or weakness, foot drop, wrist drop, or something like that, either you should think of a compressive neuropathy or an entrapment neuropathy, what you see in carpal tunnel syndrome in majority of patients with diabetes, hypothyroidism, and rheumatoid arthritis, or you need to think of a vasculitic neuropathy occurring in lot variety of diseases, be it a primary systemic vasculitis or a secondary vasculitis. When a patient develops a muscle weakness, what you think is you need to assess the muscle weakness as per your standard neurology teaching. You should assess the source of weakness, whether it is a UMN lesion or an LMN lesion. If it is an LMN lesion, is it an anterior one pathology or a nerve pathology or a neuromuscular junction pathology or a muscle pathology? So each and every level of the neurological inflictions can be seen in patients with rheumatoid arthritis. So based on the organ involvement, based on the level of muscle weakness, you would be able to corner down diagnosis. Like for example, if a young female, sorry, not a young female, if a 35-year or 40-year-old female who presents with transverse myelitis and vision loss in the right eye, and patient also has Zika symptoms. So this is going to be the NMO spectrum disorder associated with Sjogren syndrome. So like you can keep talking about diseases to diseases, and that you would learn out by experience. So coming to stroke, so stroke can be a presenting manifestation of antiphospholipid syndrome, especially while we're dealing with stroke in young. Not only antiphospholipid syndrome, patients with lupus, patients with ANCA vasculitis are at increased risk of stroke. And last but not the least, majority of your inflammatory rheumatic diseases are associated with accelerated atherosclerosis, thereby leading to MI and stroke. Epilepsy. So SLE is one disease which is associated with increased risk of seizures. The threshold for seizure onset is very high in patients with lupus. So you have to be very cautious in such patients. Okay, so oral ulcers can be seen in lupus. It can be seen in genital ulcers, along with it in Behçet's disease. Inflammatory disease, especially Crohn's disease, you can have ulcers in the GI tract from the mouth to the anus. Reactive arthritis patients can present with oral ulcers. Zika symptoms can be seen in patients with rheumatoid with a secondary Sjogren, lupus with a secondary Sjogren, scleroderma, and Sjogren syndrome. So dryness of eyes and dryness of mouth are hallmarks of Sjogren syndrome. Redness of eyes. So redness of eyes, what I mean is an acute onset redness of eye with loss of vision, improving with topical steroids, which is nothing but your anterior uveitis, which is again a hallmark feature of ankylosing spondylitis. When I talk about sudden onset vision loss in an elderly female, and there is an anterior ischemic optic neuropathy, what we are dealing with is again a giant cell arthritis with involvement of your posterior ciliary artery causing a vision loss. So each and every symptom might point to a differential diagnosis, and this list goes beyond in and day by day, as you learn rheumatology, as you go through patients with rheumatology, your knowledge of rheumatology keeps growing on from day to day. A very important history what we need to ask for patients is about the cutaneous manifestations. Okay, patients with rheumatic illnesses like a polyarthritis, if at all RF and anti-CGP is negative, you should always look for occult psoriasis. Not only occult psoriasis, we have to look for overt psoriasis and also for a family history of psoriasis in the first and second degree relatives. So presence of psoriasis with an inflammatory arthritis makes up an easy diagnosis of psoriatic arthritis. Livedo reticularis is a non-specific skin lesion of lupus. It can also be seen in medium vessel vasculitis like polyarthritis nodosa, also in antiphospholipid syndrome, which might give you clues on the diagnosis. Erythema nodosa, the broad differentials we have, starting from a simple post-streptococcal infection, secondary to tuberculosis, secondary to sarcoid, secondary to lupus. You have lots and lots of differentials, secondary to drugs. So drug history is very important for any rheumatological manifestation. When you have smaller telangiectasias in the face, which are called as mat-like telangiectasias, it is pathognomonic of a vascular manifestation of systemic sclerosis. And yes, as the number of telangiectasias increases, the risk of pulmonary hypertension keeps increasing. Okay, so this is a very clinically important, significant matter to be discussed. Viral infections, yes, they can present with arthritis, acute viral arthritis. Photosensitivity is a pathognomonic feature of connective tissue diseases like dermatomyositis and lupus. Patients can present with ulcers over the body, non-healing ulcers, which is seen in vasculitis, any spectrum of vasculitis. Raynaud's phenomenon, that is change in color of the fingertips on exposure to cold, okay, and getting back to normal on rewarming is characteristic of many connective tissue diseases, the important connective tissue disease being scleroderma. Nodules can be seen in different connective tissue diseases like osteoarthritis, where you get a Heberden's nodules or a Bouchet's nodules. In rheumatoid arthritis, what you get is a rheumatoid nodule in the typical location, just distal to your elbow joint. Tophaceous deposits can be mimicking some subcutaneous nodules in gout. You would have tuberous xanthomas and tendon xanthomas in patients with hyperlipidemia. You can see subcutaneous nodules similar to rheumatoid in lupus. You can see subcutaneous nodules in rheumatic fever, tender subcutaneous nodules in polyarthritis nodosa, and papules along the nail bed in multicentric histiocytosis. So the differentials of nodules goes in a very broad spectrum. Alopecia, it's a very common symptom that patients with rheumatic diseases face. They either face it because of a phenomenon which is called as telogen effluvium, or as part and parcel of the disease, example SLE, or secondary to drugs. Okay, so each and every symptom has to be analyzed in different forms, like was it trauma, was it infection, was it inflammation, was it metabolic, was it drug? The traditional way what medicine has taught us. So that is how deeper you have to go for approaching these patients. Respiratory diseases, yes, any connective tissue disease can cause pleurisy, pericardial involvement, parenchymal, and interstitial involvement. So the list goes without ending, discussing about GI involvement, scleroderma. The GI involvement is characteristic GRD you get there. Patients who present with diarrhea and arthritis, you should think of reactive arthritis and inflammatory bowel disease. When a patient is getting episodic arthritis and there is a history of recurrent renal calculi, the diagnosis is in favor of gout. Okay, when patients have dysuria, which means I'm talking about urethritis, so a post-urethritic reactive arthritis because of chlamydia can be presenting as a reactive arthritis. And patients with Behçet's disease can have urethritis, which is a sterile pyuria, which is common in patients with Behçet's disease. And they can also develop an acute gonococcal arthritis. Okay, so genital ulcers, again, it is characteristically seen in Behçet's disease, but also seen in gonococcal arthritis with gonococcal ulcers, and also in reactive arthritis as succinate balanitis. Okay, the similar findings can be seen in patients. Similar diseases can also present with vaginal discharge. A fracture because of a trivial fall, the diagnosis is very straightforward, going to be osteoporosis. Okay, if a patient suffers with ligament rupture in the young age, they are at risk of developing osteoarthritis in the future. If a patient buckles and develops sprains over the knee and the ankle, these patients are prone to have a hypermobility syndrome. So non-specific symptoms can be pointing towards any systemic autoimmune disease with fever, weight loss, fatigue, anorexia, and malaise. Thrombotic events, always look for antiphospholipid syndrome, anemia, any rheumatic conditions, obstetric complications, especially seen with antiphospholipid syndrome and patients with lupus. What are the other important aspects that you should look for? Past medical and surgical history really is important. Family history, menstrual history also makes an important hold. You need to screen for family history of rheumatoid arthritis, spondyloarthritis, psoriatic arthritis, IBD. Okay, family history of red eyes even can make sometimes significant changes in your diagnosis. Menstrual history, marital history, obstetric history is very, very important in any young female who's reproductively active and is planning for treatment for rheumatic diseases. Personal history is very important. Addictions are very important. Social history, how do he behave socially? What does he take? Alcohol, what is the quantity he takes? And all sorts of things. Drugs, yeah, is it something, the drug which is causing all the problem? Is there any allergy to the drugs? Okay, the treatment history, what the patient has received is very important, because if you repeat the same treatment what has been given previously, the patient is going to lose the confidence. So last but not the least, the most important history what you need to take is the economic status of the patient, because a few drugs in rheumatology are going to be costly, and you have to guess, you have to assess how much the patient could afford. And yes, in majority of the guidelines for treating rheumatic diseases, it is always going to be a shared decision between the patient and the treating physician. So economic status is a very, very important thing we must be knowing before treating any patient with a rheumatic complaint. So what I need to say you people is a proper and a complete history would fetch up the diagnosis in most of the time. So only if you have a proper clinical acumen about all these diseases, fetching the diagnosis becomes an easy job. Okay, so key things to understand in examination: do a head-to-foot examination, detailed musculoskeletal examination, and systemic examination. So which would add on to the history what you have taken. So this is an homunculus diagram what we use to measure the swelling and tenderness in each of your peripheral joints and the axial joints. And when you're looking at this diagram vaguely, you are not able to figure out anything. But here you can see somewhere Facebook, you can see somewhere Twitter here, and here you could see something which is called as password. So between the zeros and ones, you find some pattern of words which is making you understand that this is a word, this is a password, this is a Facebook. Okay, this is a Twitter, and anything else, I'm not able to find anything else. So this is what is pattern recognition. So patients would present with very vague symptoms, but it is our duty to recognize a pattern and fix up the diagnosis for a proper treatment. A few examples I could give you. If a patient presents with an inflammatory arthritis, with deformities or without deformities, after ruling out all potential causes, the diagnosis is going to be rheumatoid arthritis. If a patient presents with inflammatory arthritis, dactylitis, asymmetric arthritis with nail pitting, unresolving dandruff, okay, plaques, inflammation of the enthesis, inflammatory low back pain, obesity, uveitis, and a history of recurrent episodes of acute MTP attacks, which is because of gout, the diagnosis is going to be psoriatic arthritis. If a patient presents with inflammatory back pain, okay, in a young age, and he develops progressive limitation of the entire spinal movements, your diagnosis is going to be axial spondyloarthritis. If a patient develops polyarthritis after an episode of fever with history of an outbreak of chikungunya or any viral infection in the state or in the population, you should think of a post-viral arthritis or a post-chikungunya viral arthritis. If a patient presents with polyarthritis, hair loss, fever, constitutional symptoms, malar rash, photosensitivity, skin rashes, decreased urine output, systemic involvement of the respiratory, cardiovascular, gastrointestinal, and the neurological involvement, especially in a young female, you should always think of systemic lupus erythematosus. If a young male who presents with a history of alcohol intake followed by acute first MTP attacks with repeated attacks with the development of tophaceous nodules, you should think of gout. If a patient presents with polyarthralgia, stiffness, difficulty to make a fist with progressive tightening of the skin, Raynaud's phenomenon, Moscow facies, microstomia, and salt and pepper pigment changes, yes, the diagnosis is very clear, that is about systemic sclerosis. If a patient presents with dry eyes, dry mouth, skin rashes, salivary gland enlargements, lacrimal gland enlargement with polyarthritis, the diagnosis is going to be Sjogren's syndrome. So if a patient presents with polyarthritis with the V sign, Scholl sign, photosensitivity, heliotrope rash, Gottran papules, and a progressive proximal muscle weakness, the diagnosis is going to be dermatomyositis. So remember, not every time, every patient would present with whatever symptoms I discussed now at a single point of time. So majority of the time in the initial phases of evolution, your diagnosis would be an undifferentiated arthritis, which might evolve into another type of disease in the future. So recently I had to undergo with a patient. It was really embarrassing for me to how this patient worsened, and right now she's admitted. So this is a lady who came with fever, okay, about 3 months back, okay, fever with 3 months back, treated in a local hospital in terms of enteric fever. Fever settled down, but patient had persistent joint pains. So she came to my clinic with a sudden onset acute heel pain. Okay, it was just a heel pain. So we started her on NSAIDs, physiotherapy, contrast bath, and slow mobilization, with which the patient's heel pain started improving. Okay, I was happy. Okay, the patient is doing well. The patient is not having any systemic symptoms, but the patient was always feeling tired, hypochondriac about her symptoms, which made me even get a consultation from the psychiatrist for a somatization disorder. But what happened on the follow-up is for 2 months she was afebrile, and suddenly she started throwing spikes of fever with blurring of vision, headache, and diplopia. So when we consulted an ophthalmologist, it showed a rot spot in the eye. Okay. With just 2 days of fever, we did an echo, and the echo was showing infective endocarditis. Okay, so because the patient was totally afebrile for the last 2 months, I was not keen on evaluating the patient for PEO, but all of a sudden the patient started having a high grade fever for 2 days with blurring of vision and headache. MRI was done normal, CSF is pending, it is supposed to be done today, and the cardiac evaluation showed a large vegetation sitting on the mitral valve. So pattern recognition is not as easy as we think. You have to follow up the patient, you have to document whatever you are seeing with the patient. And I was in fact documenting every time to document the fever, no fever, no fever, no fever. Things were going in an alternate way. And at last, we are happy that the patient got diagnosed. So patients with infective endocarditis do present with arthralgia and arthritis, but not with soft tissue rheumatism. She presented with heel pain on one day. She presented with the trapezial tenderness. She presented with rhomboidus muscle spasm on one day. She had muscle triggers fleeting over every from place to place, place to place, place to place. So it was really a hard time for us for the past 1 month. At least we got a diagnosis at this point of time, being infective endocarditis. Yes. So apart from this, you need to recognize different patterns of joint involvement. So till now we discussed about joint disease with a systemic disease. What is the way you recognize the pattern? And right now, among the joint involvement, what are the ways of joint involvement and how would you approach these patients is what we should discuss. A joint symptom can either be an acute arthritis or a chronic arthritis, okay, less than 6 weeks or more than 6 weeks. It can be a monoarticular, a single joint pathology, oligoarticular up to 4, and polyarticular more than 4. The onset of symptoms can either be additive, migratory, fleeting, or intermittent. Okay, it can either affect your appendicular skeleton or the root joints like hip and shoulder, or your axial skeleton, which is your cervical spine, dorsal spine, lumbosacral spine, and sacroiliac joint. It can involve either the small joints and large joints. It can be either symmetric or asymmetric. If I want to give you one example for each disease, a patient who presents with an acute arthritis in the first MTP joint, the diagnosis is going to be gout. If a patient presents with chronic knee pain with a mechanical joint pain and crepitus, the diagnosis is going to be osteoarthritis. A monoarticular disease, it could either be osteoarthritis or gout. Oligoarticular disease, if a patient presents with an asymmetric pain and swelling in 2 or 3 joints with a scalp lesion on the head, so it is going to be a psoriatic arthritis causing oligoarthritis. If a patient presents with a chronic symmetric inflammatory polyarthritis, with all other secondary causes being excluded, the diagnosis is going to be rheumatoid arthritis. Additive arthritis is a very characteristic pattern seen in rheumatoid, psoriatic arthritis, and reactive arthritis. Migratory arthritis, as we know, is characteristically seen in patients with rheumatic fever. Fleeting arthritis can be seen in vasculitis and some autoinflammatory syndromes. And these patients can also have intermittent arthritis, what we call as palindromic rheumatism. Okay, so the pains can be either peripheral or central. Majority of the patients with rheumatoid arthritis would have peripheral arthritis. Majority of the patients with spondyloarthritis would have an axial involvement, which is more commonly involved. And patients with osteoarthritis can have both axial and appendicular symptoms. So small joint involvement is seen in rheumatoid, whereas large joint involvement is seen in inflammatory bowel disease or reactive arthritis. Okay, so symmetric arthritis is characteristic of lupus and rheumatoid, whereas asymmetric arthritis is characteristic of spondyloarthritis, especially psoriatic arthritis. So we can keep on discussing the patterns. So these are a few examples to just show you. So whatever systemic autoimmune rheumatic diseases, what I listed in the beginning, can be the differential diagnosis for inflammatory arthritis. So your history should be focused on each and every individual disease, each and every individual extraarticular manifestation of these diseases. Okay. So we discussed about RA. If it is occurring less than 16 years, we call it as juvenile idiopathic arthritis. We discussed about lupus, mixed connective tissue disease, adult onset Bell's disease, and again a diagnosis of exclusion when a patient presents with fever, rash, and polyarthritis with multi-system involvement. After excluding all potential causes, we label it as adult onset Still's disease. These patients, yes, present with inflammatory arthritis. And elderly females who present with shoulder pain and hip pain with stiffness lasting for more than 30 minutes, if they have a dramatic response to steroids, and in later they might develop features of giant cell arthritis, which is polymyalgia rheumatica with giant cell arthritis. Rheumatic fever can either be a childhood onset one or an adult onset one. In India, being a high-risk population, you can expect attacks of rheumatic fever at any point of time. Jacquard's arthropathy is a deformity which is reversible, which is correctable. When you place the hand on the hand with the deformity on the floor or on the table, the deformities get corrected, which is characteristically seen as a complication of rheumatic fever also in patients with lupus. And all your spondyloarthritis entities would be having an asymmetric involvement, and these inflammatory arthritis would be having a symmetric involvement. Osteoarthritis, CPPD, which is the pseudo-RA type of CPPD. Hemochromatosis would present with a symmetric arthritis, which is a degenerative cause, whereas gout and a pseudo-gout type of CPPD, that is a patient who presents with an acute knee arthritis with effusion, can present as an asymmetric monoarthritis. Whereas a patient presenting with chronic inflammatory polyarthritis of the wrist and hands, you do an X-ray and you find chondrocalcinosis and cartilage calcification. It is a pseudo-RA type of presentation with CPPD. So CPPD can present either as a symmetric arthritis or an asymmetric arthritis. Among the infections, the viral arthritis is occurring symmetric, whereas infection causing arthritis would have a bacterial arthritis. And yes, infective endocarditis is an important differential diagnosis for arthritis. Again, in my patient, it was not an arthritis, it was just a soft tissue rheumatism. So we have to keep our minds open, and investigate as much as possible before we reach a proper diagnosis. There are other miscellaneous causes, your infections, your metabolic diseases, your autoimmune diseases, your malignancies. Anything can cause, or endocrine disorders, okay, anything can cause joint symptoms. Okay, right. So when you take a patient with chronic arthritis, okay, if the patient has no possible other explanation for any other type of arthritis, and if the arthritis is going to be a chronic, symmetric, inflammatory polyarthritis, the diagnosis is going to be very simple, that is rheumatoid. Okay, if a patient presents with asymmetric arthritis with scalp psoriasis or nail changes or skin psoriasis or a family history of psoriasis with some amount of axial involvement, the diagnosis is very clear, that is psoriatic arthritis. If a patient presents with acute onset lower limb dependent asymmetric large joint arthritis after an episode of diarrhea or urethral symptoms, it is reactive arthritis. If a patient presents with insidious onset inflammatory type of black pain, which is progressively causing deformities in the axial skeleton with fusion of the sacroiliac joint, it is ankylosing spondylitis. When a patient presents with peripheral arthritis or axial arthritis with IBD, it is enteropathic arthritis. And patients with gout initially used to have only acute attacks of gout, and slowly and steadily, if the patient does not get treated properly, they start having a chronic polyarticular phase with tophi and erosions. So while we look at the non-inflammatory causes, first thing is osteoarthritis, second thing is soft tissue rheumatism, joint hypermobility, and fibromyalgia. So I've seen a lot of patients getting a rheumatoid factor done out of fear for having a joint pain and coming to me, and it becomes very difficult for me to counsel the patients and say that you just have a hypermobile joint and you don't have a arthritis per se. Fibromyalgia is the worst of its kind to treat. Patients would have polyarthralgia, patients would have myalgia, patients would have fatigue, unrefreshed sleep, cognitive dysfunction, depression, other symptoms like non-ulcer dyspepsia, migraine, irritable bowel syndrome, and all sorts of mind-associated or psychological symptoms or multiple somatization complaints. Yes, so this is seen in patients with fibromyalgia. So previously what they said was fibromyalgia is a diagnosis of exclusion. You should rule out all the causes, but now it is not so. A patient with rheumatoid can have a coexistent fibromyalgia, A patient with an infective arthritis can have a coexistent fibromyalgia, like what I told in my patient with infective endocarditis had a coexistent feature of fibromyalgia. So when you label a diagnosis of fibromyalgia, it is not only that you treat the patient for fibromyalgia, keep a look at the symptoms of the patient so that you diagnose something other than fibromyalgia along with fibromyalgia. Okay, so connective tissue diseases like lupus, PAN, Behçet's syndrome, or undifferentiated connective tissue disease, scleroderma, and Sjogren's syndrome, any of these diseases can present with a chronic inflammatory polyarthritis. While we talk about acute polyarthritis, again the same connective tissue diseases, what we discussed till now can present either as a chronic polyarthritis or an acute polyarthritis. To be very, very specific, viral arthritis can present as an acute polyarthritis. Okay, and septic arthritis in very rare cases can present as an acute polyarthritis. Subacute bacterial endocarditis can again present with an acute polyarthritis. Okay, so these are three important differentials for acute polyarthritis. Otherwise, any patient, be it acute or chronic, you have to screen for the entire list of connective tissue diseases and inflammatory joint diseases, including spondyloarthritis. Right. Pattern recognition with an acute monoarthritis, it should either be because of a trauma, okay, it should be because of a spontaneous hemarthrosis, or it could be because of a traumatic hemarthrosis, okay, or it could be because of a foreign body reaction to a plankton going into the joint and causing inflammation. Or if a patient is presenting with fever, you should think of septic arthritis, gout, and pseudogout. When you think of a periarticular pain, which is presenting at the monoarticular pain, the characteristic disease is calcific periarthritis, acute calcific periarthritis, which is nothing but because of a calcium apatite deposition disease. Pseudogout is nothing but calcium pyrophosphate deposition disease, and gout, as you all know, it is because of deposition of monosodium urate. So any patient who presents with an acute monoarthritis, three important differentials. One is infection, second is crystal arthropathy, third is hemarthrosis. So please look into these three differentials. You will be able to find out and sort out things. And sometimes an acute periarticular disease can also present like an acute monoarthritis. So this is what you should be understanding. Chronic monoarthritis, again, the differentials goes beyond extent of what we discussed. Peculiar things is infections. Any patient who presents with a chronic arthritis, always think of a bacterial, fungal, or microbacterial infection. If at all, just a minute. Okay, so infections is one important thing we should think in chronic monoarthritis. And apart from this, these malignant conditions like pigmented bilionodular synovitis, synovial sarcoma, osteoblastoma would come as surprises for you while you're dealing with chronic monoarthritis. Right. Now, what is the role of investigations? So we need to do some routine investigations to see if the patient is ready for the treatment. We look at acute phase reactants routinely, but majority of the time they don't help us. It might indicate an active disease or an inactive disease. Okay. So based on the history and physical examination, whatever immunological investigation you feel it to be right has to be performed, and relevant imaging modalities like ultrasound, musculoskeletal ultrasound, X-ray, and MRI would be needed to be done based on the costs. So finishing the pattern recognition, so the topic would not be complete without discussing about tight control and the need for vaccinations. So tight control is becoming a strategy in treating every rheumatic disease. Okay, so what we do is we find out an effective treatment strategy that is tailored to the disease activity of the patient, and we tend to achieve either a low disease activity or remission within a given period of time. Say for rheumatoid arthritis, if you start the patient on DMARDs, the patient has to improve by 3 months, and the patient has to attain low disease activity or remission by 6 months with the effective treatment strategy, which is going to be a methotrexate-based strategy. So this is what we call as a tight control of disease. So what is going to be an effective strategy? So you need physiotherapy, you need bridging steroids, and along with that, you need the help of these disease-modifying agents. So we have a lot of disease-modifying agents, conventional synthetic DMARDs like methotrexate, sulfasalazine, and leflunomide. Hydroxychloroquine has been excluded as a DMARD. It is not considered as a true DMARD. So hydroxychloroquine has been projected in a very heavy times in COVID. Again, it is not found to be useful there and here also in rheumatic conditions. Apart from lupus, dermatomyositis, very specific conditions, HCQ is used, and in the rest of the conditions like post-viral arthritis or rheumatoid arthritis, the importance of HCQ is coming down. If the patient is not responding to conventional synthetic DMARDs, we have an option of biologic DMARDs. Okay, in the biologic DMARDs, we have either bio-originated molecules or biosimilar molecules, which are going to be available in a very cheaper price. Okay, anti-TNFs, rituximab, tocilizumab, abatacept, new kids on the block like secukinumab, ixekizumab are coming up now. And we also have targeted synthetic molecules, which are called as small molecules. And tofacitinib has been approved for the treatment of rheumatoid, psoriatic, and axial spondyloarthritis. So steroids can be used either as oral, IM, or IV preparation as a bridging therapy only, and only in rare occasions patients might require a low dose continuous therapy. Okay, so this is a beautiful slide. If you want to compare the era of treating rheumatoid arthritis or psoriatic arthritis or any rheumatic disease, it is like I'm an ardent fan of Rajnikant, so I end up my slide with this Rajnikant slide. Your conventional DMARDs is like Robo 1, that is Endran 1.0. Okay, a very subtle guy, okay, who respond to everyone, who is liked by everyone. Okay, he is approachable, affordable. Okay, when Redshift is inserted, this 1.0 becomes a 2.0. So this is what is the biologics. He is very aggressive. He is very effective in treating the patients, but he is not cost effective. So he can destroy things in the way he can. Okay, so when this 2.0 entered into Endrin 2.0, at the end what we saw was a small molecule, a chitty kutti robo. So that is your small molecules. It was even way beyond in performing as compared to the biologics. But again, he is also a bit destructive. So, but still, the future is for us for this oral small molecules. They are showing a very, very, very tremendous response in treatment comparable to methotrexate. So methotrexate is the sheet anchor in majority of the rheumatic diseases. And days are not very far away where the price of these oral small molecules like tofacitinib and baricitinib will come down as much as possible, and give us more idea about using these patients, using on these patients to have an effective treatment strategy. Okay, when I Googled about vaccinations in rheumatology, the first picture what I saw was all pediatric children getting vaccinated. But our country is not focusing on adult vaccination. I hope you people understand why are we waiting for a COVID vaccine for all long of time. So if we were in the 1918, 1918 pandemic of flu, we would not be losing our seriousness to take a flu vaccine. So yes, these patients are immunosuppressed. These patients have to be vaccinated. Adult vaccination is of prime importance in especially treating patients with rheumatic diseases. So with this kind note, I want to conclude my session saying that rheumatic diseases can be multisystemic. So you need to have a proper history taking, a complete physical examination, which is essential to click up the diagnosis. And only based on your clinical diagnosis, the investigations should be added on. And pattern recognition with the systemic symptoms, pattern recognition with the type of joint involvement would be helping you to cut down the exhaustive list of doing investigations. Effective treatment strategy to be applied so that you reach the target. And please do not forget about the role of vaccination. Okay, so thank you for all. You can set your questions of fire now. And thank you for this opportunity.
Yeah, thank you very much, sir. I must say it's really a great and insightful session for all of us in the audience. So on the behalf of entire audience, as well as on the behalf of again Zydus Synovia, I must say thanks to you. Thanks for your precious time. Now moving towards some questions, sir, which has been asked from the audience. There is a question by Dr. Vijay. What is the gelling exactly? If it is degenerative disease, why stiffness occurs so early within 3 minutes after rest, whereas in rheumatoid arthritis, stiffness after 5 minutes?
Okay, so there is a very good explanation for why patients with rheumatoid arthritis would have an early morning stiffness. So what happens is when a patient with rheumatoid arthritis, say for example, has MCP, PIP, synovitis along with wrist arthritis. So while he goes for sleep, what happens is the joint is inflamed, the joint is put at rest. Okay, without much activity in the joints, without much activities in the joint. You don't press the joints, you don't move the joints like this. So what happens is the inflammatory fluid starts stagnating in the joint. Okay. So for the inflammatory fluid to stagnate in the joint, for the inflammatory fluid to stagnate in the joint, it takes a lot of time. So when the patient takes a prolonged period of rest, while the patient wakes up in the morning, before the patient opens and closes the fist, he would be facing difficulty in opening and closing the fist. That is again because of the stiffness. That stiffness is because of the inflammatory edema that has been accumulated over a period of time in patients with inflammatory arthritis. Whereas in osteoarthritis, it is not inflammation majority of the time. Okay, it is just loss of lubrication. Okay, loss of loss of lubrication, which is the problem in osteoarthritis patients. So, like when they take a rest and they suddenly try to get up, they feel something is preventing them from moving the joint. Like if there is a loss of lubrication in whenever, like even it's something like cooking on a non-stick tawa. If you use a wooden stick, you will face a comfortable cooking. But in that case, if you take a non-stick tawa and use a steel spoon for cooking, you would feel some rattling noise, and that would you would not find a smooth lubrication happening over there. So similar to that in patients with an OA when they have loss of lubrication within the joint, that would prevent them from waking up. But once they start moving, the residual lubrication that is present would take over and make the patient to get relieved out of pain. So the inflammatory fluid accumulation in excess over a period of time is the reason for early morning stiffness in patients for more than 30 minutes in rheumatoid, whereas not so in osteoarthritis. Yes.
Yeah. Thank you very much, sir. Moving on to the next question, again by Dr. Vijay only. But yeah, I'll take the question from Dr. Muhammad Mustaba Hanshir first. So when can we stop treatment of rheumatoid arthritis?
Lifelong. Okay, so treating rheumatoid arthritis very specific to be about rheumatoid arthritis. See, it is on which stage you diagnose the disease. So there is a phenomenon what we say that if you diagnose rheumatoid arthritis before 3 months, okay, if you diagnose rheumatoid arthritis before 3 months of onset of symptoms, there is a chance of complete remission. Okay, there is a chance of complete remission without any radiographic progression or joint damage. Okay, in a selected group of patients, as you see in rheumatoid arthritis, 70% of the patients are seropositive and 30% of patients are seronegative. So, in the seronegative category, they say that once attaining remission, if the patient is in remission for a period of more than 1 year with the DMARDs, okay, say for example, I put my patient on steroids and methotrexate and hydroxychloroquine as a supportive therapy, and the patient went into remission. I've stopped the patient out of steroids. At this stage, what we need to do is, apart from clinical remission, we need to look at the acute phase reactants. So first, the patient should be in clinical remission, which means the patient should be completely off steroids, only on DMARDs for a period of at least 6 months to 1 year. So there is no proper guidelines or evidence to say after what period of time you can consider stopping the treatment. But this is the hot topic of discussion in rheumatoid arthritis at this point of time. So when the patient maintains a clinical remission, you look for serological remission. Okay, if the patient was already RF negative, now the patient is again going to be RF negative or CCP negative. If the patient was anti-CCP and RF positive in the past, 1 year after the patient going in for remission, you see if there is any serological remission, that is, an RF which was positive, has it become negative, or anti-CCP which was positive has become negative. Plus, please don't get misguided by this answer that I will repeat RF and anti-CCP every 3 months for every patient. No, it is not so. Until and unless you decide about stopping the treatment, please do not repeat RF and anti-CCP regularly. So in such cases, you again need to go and do an ultrasound examination. You have to rule out presence of synovitis with the help of a color Doppler or a vascular Doppler. And these patients should not have any radiographic damage. And in these cases, you can try tapering the DMARDs. Okay. So there is no fixed protocol for tapering DMARDs. And if you taper the DMARDs, If the patient develops a joint symptom again, you have to go for the higher DMARD and maintain it lifelong. If the patient does well on tapering the DMARDs, and if the patient is doing well, you can try tapering it and stopping it off. But about 20 to 30% of the patients who were seronegative during the time of tapering and stopping had a relapse. After a few months, the DMARDs were stopped. So it is like a chronic disease like diabetes and hypertension. Most of the time, you need to take the DMARDs for lifelong. Okay, and especially when a patient has developed an established RA with high titers of RF and anti-CCP positivity, with radiographic erosions, with secondary osteoarthritis, here the treatment is going to be lifelong. Okay, so the terms and conditions are very strict for stopping the DMARDs. It is like getting any inclusions or exclusions while you apply for a car insurance. When you say, they say 100% claiming with a zero depreciation, but when you go and see at the bill, at the end of the bill, you find that no, sir, this charges they have just cut off 5% or 10%. It is something like treating rheumatoid patients also. So there are a lot of exclusion criteria, terms and conditions before you think of tapering or stopping a drug in rheumatoid arthritis.
Right, sir. Very well explained with the example of car insurance, wherein depreciation can cause.
Because I faced a trouble just recently, yesterday. I
Right.
had to repair my car bumper. So I faced the struggle.
So it's an apt correlation by the rheumatologist with the life things.
Yeah.
So there is one more question, sir.
Hmm.
Dr. Bhavna, she's asking, should methotrexate compulsorily be combined with using biologics?
Okay, so let me talk about evidence first. Okay, let me talk about evidence first, and then let me talk about what I do in my practice. So, as per the evidence, sorry, sorry, as per the evidence of management of rheumatoid arthritis, the biologics what we use. Okay, there are two things in when a patient is not responding to methotrexate and the patient is having poor prognostic features, you start the patient on biologic therapy. Okay, the use of methotrexate is two things. One, majority of the biologic therapies what they're using are not purely human. So these patients can develop immunogenicity to the biologic therapy, thereby causing loss of efficacy of the biologic therapy. So in such cases, administering methotrexate along with the biologic therapy reduces the risk of immunogenicity to the anti-TNF, especially anti-TNF. That is number one. And number two, while considering other biologics like rituximab, tocilizumab, and other drugs, excluding tocilizumab and tofacitinib, it has been proven from time beginning that administration of a biologic with methotrexate is always better than administering a biologic alone. So if you are not able to give methotrexate and you want to use a biologic, only thing which is possible is using a tocilizumab biologic or using a small molecule like tofacitinib. But what I do in practice, but this is in contrast to what we do in spondyloarthritis, evidences are not very much in favor of using methotrexate along with anti-TNFs. But in clinical practice, as we are facing with a poor population who are not able to afford biologics lifelong, as I said, you need to take methotrexate lifelong. When a patient is accustomed to biologics, he has to take biologics lifelong. So that is not quite possible in a scenario like in which we are in a resource limited setting. In majority of the times, we do continue methotrexate along with biologics.
Right.
So evidence is good for rheumatoid, combining methotrexate with biologics. Okay, evidence is not good for spondyloarthritis, but still we have to administer methotrexate for every patient with rheumatoid arthritis.
Right. Then, sir, last question I'll just take up, not taking much time. What is nocturnal pain suggestive of rotator cuff tear? Is it intra-articular, and why nocturnal pain in leukemia?
Okay, the nocturnal pain in leukemia is because of bone marrow infiltration, and the patient is having rest pain. And while the patient puts the bone at rest, because of infiltrative bone disease, patient would be having pain. That's a very simple explanation that I can give. In rotator cuff injury, the problem is the patient is having it is not, rotator cuff injury is not an intra-articular pathology. Supraspinatus tendinitis or whatever tendon cuff, rotator cuff injuries what you're facing are all external, so are all extra-articular pathologies. Okay, so again, it is because of insertional degeneration, osteophyte formation, calcification, and patient while sleeping. So the typical nocturnal pain in patients with rotator cuff injury would not be as severe as that of leukemic bone pain. So it would be like a dull aching pain, and patient would not be able to sleep on the side because that on pressing the shoulder over the bed, the patient's tendons would be irritated, and patients would be facing pain. So the nocturnal pain, what you face in rotator cuff injury is totally different from what you face in inflammatory back pain of spondyloarthritis or in a patient with leukemia. So that is how you differentiate. So the pain in spondyloarthritis and leukemia are very severe, whereas the pains in nocturnal pain with rotator cuff injury is just going to be a dull aching pain.
All right, sir. Shall I take last question, sir?
I'm welcome with any number of questions.
So how common do we encounter conditions like lupus, and how will that presentation be?
Lupus. So lupus is actually a clinical overlap syndrome between systemic lupus erythematosus and rheumatoid arthritis. I've seen a lot of patients who are being treated as rheumatoid arthritis in the beginning with all inflammatory signs, with all radiographic changes and everything classical of rheumatoid arthritis. And future they develop features of lupus. Or a patient coming with lupus can present patients with features of rheumatoid arthritis in the future, or sometimes both can occur together. It is basically a clinical overlap syndrome of both rheumatoid arthritis and SLE. It is not uncommon. Usually, the inflammatory arthritis in lupus is non-erosive, non-deforming. If at all it is deforming, it is going to be a correctable deformity. That is what I was talking about, Charcot's arthropathy in lupus. Whereas usually the inflammatory arthritis in rheumatoid arthritis is deforming and erosive. So when a patient has characteristic features of lupus, okay, all characteristic features of lupus, presents with the deforming arthritis, we make up a diagnosis of lupus. Again, this is just a terminology to fit in and explain the prognostications to the patient. The treatment of the patient is solely dependent on the amount of extent of involvement or extent of pathology contributed for the rheumatoid or the lupus. If it is a predominant arthritis predominant disease, again, the treatment is not going to change between RA and lupus. It is going to be methotrexate first. Okay, if not responding, one thing is in lupus patients, we don't try sulfasalazine and anti-TNF because they might precipitate flares of lupus. So we go with methotrexate and leflunomide. If not responding, we go for rituximab, especially while you're dealing in an overlap condition between lupus and rheumatoid. So it is still a possible entity. There are very few cases have been, which I have seen in my personal experience.
Right, sir. So with this, all the questions are over from the audience, sir, and I'm really happy that you have answered every question very patiently and very much in detail. So I'm sure that audience will be also similarly satisfied and happy with the session. And I must say it was very much in detail, very insightful, very knowledgeable, and full of experiences, in clinic experiences. So that really could help us a lot. And I'm sure that everybody in the audience will take a note of it and take important points from the session. So with this, sir, I really thanks to you on behalf of Zydus Synovia, and looking forward to you many sessions in the coming future, sir. So with this, I close the session for the day, and thank you everyone in the audience for joining us today, joining us for this beautiful session by Dr. Vignesh, who is the first DM rheumatologist of Warangal. So it's really a great and pleasure meeting you, sir, on this platform. Thank you very much, and a good night to everyone. Good night, sir.
Thank you, everyone. Have a good day. Thank you. Bye.
Bye.